Alcohol-associated hepatitis is an acute inflammatory process in the liver that occurs in patients who consume chronic and active high quantities of alcohol. The disease ranges in severity from mild to severe. However, severe disease is associated with significant short-term mortality. Hello, I'm Dr. Camille Kieser, and I'm a resident physician in the Department of Internal Medicine at the Mayo Clinic in Rochester, Minnesota. Our article is titled The Mortality Index for Alcohol-Associated Hepatitis, a Novel Prognostic Score. I have the privilege of sharing the results of our study published in Mayo Clinic Proceedings on behalf of our esteemed co-author team. Currently, there are multiple prognostic models that are used to quantify disease severity in alcohol-associated hepatitis. These include the Model for End-Stage Liver Disease score, the age, serum bilirubin INR, and serum creatinine score, the Maddrey Discriminant Function score, and the Glasgow Alcoholic Hepatitis score. Due to the broad range of disease severity seen in alcohol-associated hepatitis, clinical decision-making regarding therapeutic intervention is dependent upon accurate prognostic modeling. Importantly, prognostic modeling is becoming increasingly intertwined into an emerging yet controversial subject in the field of hepatology, including whether patients with severe alcohol-associated hepatitis should receive early liver transplantation. This clinical and ethical predicament highlights why a prognostic model with the strongest possible correlation for short-term mortality should be sought after. The purpose of our study is to create a novel prognostic score that is more accurate than existing models in predicting 30-day mortality in patients with alcohol-associated hepatitis. For our study, a cohort of 266 consecutive adults diagnosed with alcohol-associated hepatitis at the Mayo Clinic in Rochester, Minnesota was identified for model derivation. Patients were included if they met the probable alcohol-associated hepatitis clinical criteria based on the National Institute on Alcohol Abuse and Alcoholism. Demographic and laboratory data were extracted for patients with the endpoint being 30-day mortality. Follow-up was complete for all patients. Univariate logistic regression was used to identify candidate variables for the model. For the multivariate analysis, backwards elimination variable selection method was employed to determine a smaller subset of variables that would accurately predict survival. This model was then validated in an external multi-center retrospective cohort of 249 patients from the University of South Dakota and University of Kansas. Using backward selection, age, BUN, albumin, bilirubin, and INR were significantly associated with mortality and therefore were included in our model, entitled the Mortality Index for Alcohol-Associated Hepatitis, or the MIA. In the derivation cohort, the MIA achieved a C statistic of 0.86, meaning that it accurately predicted mortality more than 86% of the time. In the derivation cohort, the MIA achieved a significantly higher C statistic than the MELD, Maddrey Discriminant Function, MELD Sodium, and Glasgow Alcoholic Hepatitis score. In the external validation cohort, the MIA achieved a C statistic of 0.73. The MIA C statistic was significantly higher than that achieved by the Maddrey Discriminant Function, but not the MELD in the validation cohort. The MIA performed better in patients not treated with steroids, which was the majority of patients, as compared to those treated with steroids in both the derivation and validation cohorts. However, the MIA overall performed well regardless of steroid administration and is therefore generalizable. In summary, the MIA is a novel prognostic score consisting of laboratory variables and demographic data that are routinely obtained on admission in this patient population, and it was validated in an external and multi-center cohort. At a minimum, the MIA does compete with the MELD and outperform the Maddrey Discriminant Function, which remains commonly used in clinical practice despite its less than desirable performance characteristics. Furthermore, this study demonstrates that optimum prognostication will likely require a combination of prognostic models or the addition of novel variables such as biomarkers. While we anticipate that the MIA will continue to be refined over time, perhaps with the addition of a dynamic component or in conjunction with an existing model such as the MELD, this study demonstrates that it is a novel and useful tool in assessing 30-day mortality risk in patients with alcohol-associated hepatitis. Thank you for your attention, and we hope you enjoy our study.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.